So this is going to run somewhat like a panel discussion. You're not going to have an opportunity to ask further questions. If you do have any further questions, please note them. If they go up on the parking sheet, we'll make sure responses get back to the full room. And by the way, all speakers have seen the questions previously, so we'll see how we go. So we're going to start with Chuah first. And first question is related to the overall direction that the ministry is taking and how can we get on the bus, and it's talking about the DHBs as well as providers being on the same bus. So Chuah, what is the overall direction that the ministry is taking and how can we all get on the bus? Ben's our technology man. He says it should go.
Hello. Can you hear me? Yep. Well, I want to start off by saying apparently at the end of the day there's a draw.
Yes.
And apparently whoever wins the draw is going to spend an hour with me. And I will go to whoever the person's office is. And it's for an hour. And I thought, I haven't discussed this with the organizers. And I thought an hour is really not sufficient to get into the details. So we'll make it 2 hours, and I'm buying lunch. Right, okay. So you have the question which is about the DHBs are driving the bus. Sometimes they don't stop for other people to get on. And when the money stuff gets a bit tight, they sort of do things and reduce services and things like that. So we are actually asking the DHBs to do a number of things. We are asking them to look at how they work with other providers apart from their own hospitals. And the most obvious one at the moment is quite a lot of engagement going on with the broader primary care around what is the next stage of progress between the DHBs and primary care. There are various levels of discussion engagement with other parts of the sector by the DHBs, and I would agree that those things are quite variable and patchy. With regards to reducing services or when the finances become a bit tight for them, one of the things, in fact, I was up at a DHB yesterday talking to them on this particular issue and actually reminding each other what our primary collective responsibility is, and that is to actually look after the health and well-being of New Zealanders first and foremost, right? And it is not acceptable for DHBs to be cutting services as a means of balancing the books when the services are actually what is required. Now that doesn't mean that they can't look at the services they're providing and actually making decisions around thinking some of these services need to be enhanced, done differently, or even stop some of those, provided that they have actually had a process of engagement and discussion with multiple stakeholders, and that includes the community, and that includes the providers, and that includes us. Okay? And because we are quite clear, and we reminded DHBs around their commitment to the New Zealand Triple Aim, which is about we have a responsibility for excellence in looking after individuals, excellence in looking after population, and excellence in managing our resources and living within our means. So that's the conversation we're going on. So the DHBs themselves are realizing they have to change the way they are engaging and going about actually doing their planning, particularly around not just this year, but actually ongoing. Now, I would agree, and I get feedback from various community groups that their experiences with DHBs are extremely variable, and for some of them they are improving, for some of them they're staying still, and for a few they think that it's actually going backwards. So my encouragement to them is you need to let the DHBs know where they stand, and we are quite happy to be copied in, so that we can also pick up the conversation. Sorry, that's a long answer to that question. Michael, but I haven't said question, I'll talk to you later.
The other question that relates to general direction is stated as, in keeping with the government's policies to increasingly privatise public assets, do you believe public health services in New Zealand are likely to be privatised, as seen in the UK and elsewhere, and if so, implications for health and disability NGOs?
Okay, so this is quite an interesting question because we can go all over the place in this one. Can also be quite philosophical about this as well. And for those of you who know me, I'm not philosophical at all, I'm quite practical. So, as an onset, let's remind ourselves, 67% of those who provide public health services to New Zealanders is actually the private sector already. So it's not like, that the public sector has got a big chunk of this stuff. Now, I think the essence of the question here is that as we look forward in terms of what is the better way of actually providing services to New Zealanders, is there a deliberate policy to actually privatize more things, to the private sector sort of stuff? So the short answer to that is not in that specific term. But what we're asking the DHBs to do, and it's actually related to your first question, is when the DHBs are looking at how they plan and how they want to deliver the services, are they engaging with providers, right? And that includes the private sector. Because some of the conversations that's going on is about, so here's a good interesting example, right? So if DHBs carry on the old way of doing things, which is they plan capital investments running into the tens and hundreds of millions, but don't actually talk to their local private provider, and they also plan some tens and hundreds of millions, at some point we're going to have an issue around capacity and duplication. So the encouragement really with DHB is say you have to talk to your providers, be they be public or private. Okay.
So quite a lot of questions later on ask more detail about the nature of the relationship between DHB and provider. I'm going to move the questions more to a different area. This one talks about the optimum makeup and shape of the NGO provider sector. So does the ministry have a view of what that shape might be in, say, 5 years' time, particularly about the ideal size of the organisation that combines effectiveness, efficiency? Thoughts on that, Chuah?
You ask good questions. Really good questions. So I think this is under the general theme of where as a society we're going, right? And also around under better public service. And I want to deliberately use that word because it has got a lot of meaning to me, okay? Because what we're trying to do is to realize that actually the days when we work in silos and by ourselves is no longer sustainable, and neither is it going to be effective, right? For one, things are moving and changing so fast, okay? So we actually do need to leverage off each other. So as in public service at the moment, so all the social services departments are asked to actually look at how we work with each other a lot better. Likewise, we're asking the DHBs to look at that, and I would also encourage the NGO sector to do that. Now, some of you are actually doing that already, and I think that is absolutely the right direction. Now, if you're looking for a magic formula around what is the right size and configuration, I'm going to disappoint you by telling you I don't think there is one answer. So I think that you need to constantly look at where are the opportunities to work with each other, to collaborate, and where it is appropriate and actually delivers the right outcome for the amalgamation, the collaboration, consolidation, whatever you want to call it, to actually come together to do that. Because I think the days of us trying to work independently, no matter how good we are in what we do, I think is coming to an end.
And the consistent themes around working together across the sector, DHBs working with providers shaping their own future, and I think it's probably quite heartening that the Ministry doesn't have an end game in mind about the size and combination and structure for the NGO providers.
Can I rattle on a bit?
Yes.
Yeah.
Small.
Small rattle. A little rattle. So one of the discussions that's going on, and you in your sector may have heard about it, is, I think it's actually related to the questions, I'm jumping around. Yeah. To move away from a traditional sort of, quite transactional contracting approach towards much more of an alliance contracting approach. Some of you may have heard the words and stuff. So, if you get into that whole alliance contracting stuff, it actually builds on what we're talking about. Alliance contracting requires multiple funders and multiple providers to actually come together to co-design a solution based on an outcome, okay? And that actually answers quite a number of the questions down here. But it presents an interesting opportunity, but also significant challenges on each of us individually around how we're going to conduct ourselves when we get around the table.
So, looking at the alliances as it relates to finances and contracting, I'm going to try now move to Richard. There is a question, and it dips into some detail, but I think it's a good question. With NGOs having to be increasingly cognizant to keep overhead costs down and deliver best value for each dollar, what moves have the Ministry of Health made to rein in their spiralling overhead costs?
Our spiralling overhead costs. Not many of you will know, actually. I started at the Ministry of Health 4 years ago. We spent $217 million running the ministry that year. This year we'll spend $177 million running the ministry. That's $40 million less to basically push out the same set of goods and services. It's been a bloody tough 4 years, to be honest, and I think the organisation internally has certainly taken some pretty severe hits in trying to do more with less. But there's very few organisations in the private or public sector that are running at 20% smaller budget than they were a few years ago. I'd have to say too, that $40 million that's come out of the running costs of the ministry has gone straight back into frontline services. It has not gone in to help the Minister of Finance balance his books. It's been reallocated through the Minister and via the risk pool back out again.
And I'm going to go with the Chuah, yes.
Yeah, okay. Could I just, a couple of other things. Just to feedback on some of your answers there, Chuah. The issue about privatisation and so forth, that's not the signal that we're getting from ministers really. The signals that come through time and again is get better joined up, be more innovative and more open to suggestion about how to do things differently, and start focusing on the outcomes of what you're trying to achieve instead of just traditional models of delivery and so forth. And I haven't heard the word privatisation or further use of the private sector in any of the last 4 years really. Sorry, John.
Yeah, we haven't planned this, but I was just going to support Richard in terms of the ministry one, because I noticed that she's quite a lot of my staff here. And they would know, actually, I'm quite stroppy around when they come and request for more staff, isn't it, Graeme?
I don't want to go there.
But I just want to support Richard in saying that we look quite hard at what resources that we have. And our first response when we're asked to do more or new things is not to ask for more money. It's to actually ask ourselves around whether or not, based on the resources that we have, are we doing the things currently the best way we can do it? Can we free up the resources to absorb and actually do the new things? So we're constantly asking for that. And just to back up Richard's high-level information on the dollars, in one of my areas, we've lost 120 staff in the 3 years I've been there, out of a complement of 360. Right. In another area, out of 200, we have lost 50 staff. Right. And that has not been actually at the expense of actually less service. It actually has been about a better service. Right. So we're constantly asking ourselves.
Yeah. Thank you for the commitment. And this is another money question. When can NGOs expect to receive realistic funds for their contract services? That is a Richard-directed one.
Yeah, I get all the easy questions. And there isn't a second prize of an hour with me either, I think. You kind of know what I'm going to say, I think. Really. But look, I mean, your comments before, Chuah, about alliance contracting. My first experience with alliance contracting came with some large construction contracts a bit over a decade ago, and the driver behind a move towards alliance contracting in that particular set of cases was actually around running out of money, and we had to find a different way of making the same dollars stretch across a very large complex project. So alliance contracting was actually about sharing risk and about having an adult informed discussion about what everybody was trying to do, but there was certainly no more money on the table, and I think so it is with the sector as well. I think the good old days of FFT and demo and of the health sector getting $750 million a year worth of new money is just long gone, and it's not going to change anytime soon. And as public servants, we're all just buckling down for a solid decade of a fairly tough time, I have to say, and inevitably that affects all of you as it affects us, as it affects the DHBs. It's not necessarily a good message, but I'd have to say what I've seen in the allocation of health funding in recent years is it's got a lot tighter. You know, we haven't watched hospital waiting lists grow, and we have actually tried to maintain frontline services. We have tried to shift resources as well, particularly the noisy services like hospital EDs and so forth. I think we're doing a reasonable job in trying to keep as much as we can at the primary care end and at the NGO end as well. I know it's tough out there.
And we're getting consistent reminders throughout today from the Minister and also from you, Chuah and Richard, around the tightness in the economy, equally the importance of working together, and Chuah and others of you equally are leading examples of delivering services in shrinking budgets. And as we look at contracts again, I'm going to the question that talks about time period. Right. So when will consideration be given to moving to a 5-year time frame rather than a 3-year period for contracts?
I think about this time last year we had a discussion internally about the annual contracting round. Like, you know, it just goes crazy every year about this year as we try to renew thousands literally of contracts across the sector, and frankly it kind of kills us. The discussion we had about 12 months ago though was it's just not good enough to throw everything onto a multi-year contract and you know, reduce our compliance costs and yours really. And one of the criteria we put around moving to multi-year contracts is we have to have had a look at the service to ensure it still represents what we want to buy, it's still delivering good value, and it's still what we want to be doing in 3 to 5 years' time. So we are endeavouring to move to multi-year contracts. We're also endeavouring to move to cross-government contracts as well, as a lot of you will know, through that MB initiative and also connected to the MSD's Investing in Services for Outcome project as well. So we are trying to work across government and to have a smaller number of longer term contracts. But it does come at a cost of an expectation that we have a good hard look at what we're buying as well.
Yeah. So coming back to those outcomes and delivering results. Yeah. There are some questions that relate to what details might be considered in the nature of the contracting costs, i.e. Regional differences, things to do with travel costs, pay equity, etc. I'm going to leave those to be answered online because they're going to be easier to do that, and I think you'll still get a response. I'm going to move out to an example of innovation. So it's about a connection, or it's about DHB changes in elastic stocking suppliers. And so Tony talked about some of the innovation, so don't focus too much on the stockings. It's the issue. So it relates to a bigger issue. Suppliers and end users being involved in the procurement initiatives at a consultation level. For example, DHB spend a lot of money on home care visits for people who require assistance to put stockings on, but there may be more efficient ways of doing this. So what is the policy on changes to procurement contracts for consultation involvement with the NGOs so that good decisions are made?
Yeah, look, I'd have to acknowledge, I think it's an area where we haven't been so good and where we need to be a lot better, I think, really. You know, there is a tendency to look at the service, to look at the contract, and to think about it in terms of price volume schedules and how to roll over the same contracts for less. And we really do have to get a lot better at looking at different ways of doing things. I've mentioned the initiatives around investing in services for outcomes and having a more outcome focus to it. I'd have to say I saw a Treasury report the other day that had gone to the Minister of Finance and talked about contracting for outcomes, and the Minister of Finance had written, just get on with it at the bottom of it, actually, which is a pretty simple message. But again, I'd have to acknowledge there's still a tendency for folk in Wellington to look at that and to nut out what a good outcome looks like and to write the paper around it and so forth, and we do need to get a lot smarter at engaging with the sector. I could draw another example. I had a chat to some of you a week ago, and I was waxing eloquent about the joined up contracting and so forth, and somebody down the back of the room said, yes, but when are you going to come and talk to us about what it is we actually do? And I didn't have a good answer then, and I'm not sure I've got a good answer now, but I do acknowledge the problem, and I do know we need to get better at it. You know?
Changes, more changes to happen. Going to move to IT. So for Graeme, we've also talked about the importance of IT earlier today. General question, is the IT board looking to centralise IT services going forward, even regionally?
Yeah, thank you. And I thought the Minister did a very good job when someone asked him about an IT project to do with Orion and the South Island. So it shows you that IT is being managed right through CEOs and all the way to the Minister now. Are we looking to centralise? So it's a little bit like a question about privatisation. We don't have a mad goal to centralise, but we are looking for opportunities where central and regional options work. And in fact, you'll be aware already, or you may not be aware, that in New Zealand we've had a number of central systems running in health for over 20 years. So we've had an NHI system predominantly used by GPs and DHBs running for 20 years that we're just about to replace that with a modern system. And the point about that is it will be a much more web-based system that will allow a range of other organisations to also use the NHI with their patients and with their consumers. So where it is sensible to have a national single system, we will do that. Another example is medications. So we are going to have national systems for the way medications are prescribed in the community and in hospital. They won't be a single system for both, there'll be one in each area. However, where clinical activity is occurring, where there's a workflow, where there's a journey that we're taking consumers on, we are wanting the systems to be closer to the way the actual pathways are developed through community, primary, secondary services. So our next step then is to have a range of regional services, and that's things like the Orion Clinical Workstation. It's about primary care, being able to link into the local ED, and they're going to be managed at a regional basis. So some national and central and some regional, and as little as possible of local, because that's where we get caught with both cost and interface and integration issues.
So at the local level, there's a question here related to small, medium NGOs. What assistance can or will the National IT Board be to small to medium-sized NGOs which struggle to fully utilise all the functions of the IT software and hardware they have?
Look, I understand, and a couple of thoughts. Firstly, the IT board, when it came into existence about 3 years ago, had a bigger problem to solve first, which was, to be frank, the journey that consumers were going through across the health system was not joined up. So that's what we put our focus into. We're about to be releasing later in this year our strategy for the next 4 years, and it is likely to take a much broader social services orientation along the lines of the social sector forum discussion that we heard the Minister talk about. And have a look, keep an eye out for that, because what is likely to be needing to be found is some sort of shared care solution that allows multidisciplined organisations and players to be surrounding the person and their information and their objectives, what they're trying to achieve, which won't be just medical, clinical, but obviously a wider range of services. Now, I'm not saying that that's going to instantaneously come about, but that's the focus area we'll be putting over the next 4 years. So the first point is look for those national systems you can be part of, and I've mentioned the NHI, which is one that you can start becoming part of over the next period. The second thing for smaller organisations is do not be convinced that these IT systems are going to solve problems for you overnight. Let me use an analogy of a car. If you had to buy a company car, we don't go and buy the Ferrari, do we? We go and buy the Toyota Corolla, and then we manage it and we make sure no one takes it home over the weekend, or if they do, they don't go driving to the Coromandel and back. You know, we really look after our private vehicles that we're using in our businesses. So our IT system's no different. Buy the IT system that does the job, that you're confident in, that does just the role you want it to, and make sure you watch what everyone's doing with it, because you're custodians of the information of the consumers that are going into that system. So I want lots more Toyotas out there, and make sure they work really, really well. And the last comment I'd make is we do want to hear from you. You know, if you're in that difficult position of needing to upgrade systems, you're very welcome to give the IT board a ring. We certainly can't come out and do a full planning session with you, but we'd be very happy to give some advice and to be a clearinghouse and link you up with other organisations that are going through similar experiences.
Thank you. Reminders of working together, and thank you for your commitment. As you were talking around the linked and joined up, there are two questions, in my view, quite connected. What progress is there on the integrated information systems and the sharing of medical information between health practitioners?
Yeah, so look, there is progress happening. Let me give a couple of examples, and I know these are more clinical, but as I said, we had to focus somewhere. So you may or may not be aware that one of the systems we rolled out a year ago is GP to GP. So this is when a consumer chooses to leave their GP because they're moving town and they go to a new GP. Now electronically their history in the primary healthcare area can be moved to the second GP. Now that's a huge and important step forward, because that means everyone's primary healthcare record is now following them to the GP that they're getting services from. Now here's a funny story. We thought there'd be about 2,000 a month. So we watched as it went live in April, and this was April last year, there were 93 I think the first month. Do you know we had 14,000 last month? 14,000 transfers of consumers' personal records from primary healthcare from one provider to another. And that just says to me, sometimes we don't know the demand that's out there. So it's a very simple system. Now, another one that I'd like to share is referrals. So referrals, again, it's starting at general practice, although if you're in the Midland region, it is more broader than that. But there is a referral system in each of the 4 regions, and it's running at 35,000 electronic referrals a month. So just imagine the connections that are now occurring, and the benefit of that is general practice and other providers are referring to specialists and hospital specialists, and not always having to go to the hospital, because the hospital specialist reviews that referral information and is able to send advice back to the primary care environment and suggest that that person can be managed in the community with a certain set of advice. So it is actually about getting the communication going. Now, I said earlier that I'd like to give more focus to the NGO community over the next 4 years, but we had to start somewhere, and there's a couple of examples.
Thank you for that. There are some other questions about the IT board and its role around providing information back to the sector. I'll leave those questions for now. Further information will come out to you. So Chuah, I'm going to turn back to you. Questions related to the direction and activity of the National Health Board. So the question here, page 7, if you want to reference it, that's our page 7 by the way. How is the Ministry of Health National Health Board working to support the culture change required at PHO practice level that will bring closer collaborations with NGO at the community level?
Well, the first thing I would say, culture change does take time. And the second point I would make would be is, when we talk about culture change, it's such a broad word. And what I mean by broad is that there's broad interpretation of what that means. What I'm trying to read into the question here is actually about getting the collaborations between PHO and general practice level with the NGOs at a community level. That's the essence of it, right?
Yeah.
And it comes back to my point around alliance contracting. Okay, so when we talk about alliance contracting, and it's a strange way to start because those of you who know me, that I'm not a great fan, start the conversation around contracting. But I think at the moment, the alliance contracting provides a good platform because there is a prerequisite before we get into the contract discussion, which is one, have we got the right people around the table? Right? And that's a very important question. So therefore, in terms of alliance contracting, looking at the broader continuum of how we look after people. So while we are starting to make progress of alliance contracting engagement between the DHBs and primary care, I think equally, I think the question asked us here is that should the NGO providers be now brought into the alliance contracting discussion? And the answer to that is obviously yes. Because one of the things that's quite evident to many of you is that you look at this stuff and you're actually saying, we can actually do more. And some of you are actually growing into those services. But the challenges that we have is that when we grow into those services, we are starting to do something that somebody else is already doing, or they think that it's actually their patch. Okay? And the challenge we have is actually having those disparate conversations, not having everybody around the table. And that is where everything sort of gets jammed up. So if we want to go forward, I think it's getting everybody around the table, not talking about the money, but it's talking about what is actually the right thing to be doing for the individuals and the consumers around when we look after them, and not just always talking about the hospitals and the GPs, etc. sort of stuff. So things like.
And there is quite a consistent theme coming through from the three of you around the importance of having the right people involved in the conversation directed towards improved outcomes. Innovation, different ways of working, certainly coming through. I'm also hearing in the nature of the questions, what is the ministry or the NHB doing to support that change and movement towards working together, collaboration? This particular question is, how is the ministry and NHB supporting the move of services from secondary to primary? And it could be, I think, any move of services closer to the people that need them.
Yeah. So this is a very timely question because we are right in the midst of working through with the DHBs around finalizing their annual plans and the regional services plan for the year 13-14 starting, right? Now, and those of you who are involved in this sort of stuff, the guidelines are pushing the DHBs and stretching them to say, we actually want some specific examples of what services that your secondary services are going to stop doing or change the way they're doing, and actually how they will be done in a primary care context. Now, that guidelines there is an invitation to DHB to say, this is not saying that you should willy-nilly just shift stuff because we ask you to shift stuff. Right? This is actually about saying, what are the things, when you're engaging with the primary care clinicians, the GPs, the pharmacists, and so forth, what are the things that they say they can do for you that currently you're doing, which if you work that through with them around what that patient pathway looks like, is a much better patient outcome that they should be doing. Okay? Now that is a specific request of the DHBs, and by the way, we are also very interested that when they name the services, the most important thing for us is to be satisfied for them and for us that this actually results in better service and safer service for the individuals and the consumers. Right?
So we've heard the emphasis that the ministry is placing around national, regional, supporting the right things happening in the local area that makes sense for those needing the service. We're running out of time on specific questions, but all 3 and 4 and the working group, we've all had an opportunity to look at the 50 questions. We'll get back to you. However, I'm going to ask if there is one more question or comment that each of you would like to make in response to a question raised, knowing that we will ask you to give responses to all of these. So just while we have this group gathered, what kind of any response you would like to say, offer in summary?
Look, I think I said earlier that one of the strengths of the IT board, we've made a very strong statement that, as the Privacy Commissioner did, that all the information that is collected by all of us as organisations, it is the consumer's information and we must be their custodian. There was a question in here that asked about the complexity of IT projects. And I get asked this a lot because we are involved in all sizes of projects. And I just want to reinforce there is a very well thought through 3-stage model around major IT projects. And if you're involved in an IT project, and many of you will be involved maybe on the periphery or on the side of a major project or right in the middle, if you're not feeling good about it, we'd rather you told us about it early. And I'll give you an example of a group that's done incredibly well. Plunkett are doing extremely well with their Plunkett Plus solution, and they've followed the 3 main tenets, and I'll just very quickly give them to you. The first one is, when you get a new system, make sure it just does the basics well, and when you go live, make sure you've got your security, you know what people are accessing, you know what the consumer outcome is going to be, you just keep it very simple and very focused. Then you spend time on stage 2 to improve things, improve the processes, maybe have links with other organisations. That's step 2 because you know you've got a good base. And step 3 is when you allow others to have a look at the information who don't work for you. So you might have a consumer looking at it, you might have other organisations partnering with you. Now the real trick is not to go to step 3 first, because you actually don't have a basis to build on. And we find ourselves a lot advising organisations through the whole health sector, they just rush to step 3 and they haven't nailed step 1 and 2, so keep that in mind.
And for those that are engaging in IT projects, I'm sure the IT board will avail that 3 stages for you.
Very happy to.
Okay, thank you. Richard, I'm wondering if you have a thought.
Yeah, I mean, just echoing your comment there, Graeme, about complexity and so forth. I mean, I've been in health for 4 years now. It's an incredibly complex sector. I find it really fascinating, and it's really difficult, actually, you know. Young people, old people, NC, you know, just that acronyms, the range of things that we're trying to deal with in the community and so forth, the players in there, NGOs, big pharmacy companies and so forth. It's a fascinating and really complex sector. I think what we're doing now and where we're headed is right, actually. I think the days of big hairy-chested change is well and truly over. A, we can't afford it, and B, it's just too difficult in such a complex sector. So I think there's a real emphasis on getting thousands and thousands of little things right and pointed in the same direction. It's much less visible to people, actually, and I think it can be quite frustrating because people don't get that same sense of grand change taking place as you do with those big work programs. But I think ultimately it's more effective, and it's a challenge for all of us, really, and I thank you for sharing the journey with us, really.
Thank you, Richard. Final comment, Chuah.
Yeah, I'm just going to break the rules a little bit, and rather than sort of look at the theme of the questions, I just talk about some final thoughts for the meeting, really. I was asked some time ago around what are the three things, if I had a magic wand, what would the three things be? So the first one, I think, is that I think as a sector, we need to actually focus on how we need to work with each other, and so the whole theme of better public service, collaboration, DHB sort of stuff. So I think that's quite a fundamental thing because of the issues around, the sector is changing so fast. We all understand that health can't stand alone. There's broad determinant health and so forth and so forth. So this is the biggest challenge for us. Is actually about how do we actually break down the silos, not in a structural form, but also in our thinking. So that's the first one. The second one, I think, is also about I think we need to see much more participation and involvement and engagement with the community, with the users and their families, right? Because I think Richard made an interesting point. So we in Wellington sometimes sit down, with all our masters and PhD people and crafting all these wonderful solutions. And actually, when I was in the DHBs, it was true also in the DHBs, So you had very qualified people thinking that they knew what the answers was for the community. And I think that increasingly, we've got to stop doing that. We've got to stop actually involving and drawing the community and the patient families in. And the third one, because we're in the health sector in terms of some of the immediate issues, is actually about and this has got slightly narrow focus, but I think it's important. Because of the fast changing nature of health science and the research is coming out, we need to actually have our clinicians, and I'm using the broader word clinicians, actually needing to know how to work with each other, right? Because I think that there are some opportunities there, but there's also significant risk if we don't. So these are my three magic wand moments. Those are the bigger bus ones.
Bigger bus. Yes, that takes us back. And I guess for me, again, it's that reminder of it's the people at all of the levels and across. Thank you for the sum up. I'd like to thank all of you, particularly those that fed in your questions. Responses will come back out to you, and I'd like to thank the three of you on behalf of the group for considering and your thoughtful responses to the questions that I gave you time for. So thank you.